Aloha and welcome to the launch of the Prevention Services 2.0 webinar series. Thank you for joining us today. This series was created by Hawaii Partnerships for Success, a public health initiative that works to address one of the nation's top substance prevention priorities, underage drinking. HPFS is funded by SAMHSA, the Substance Abuse and Mental Health Services Administration. It is based at the Alcohol and Drug Abuse Division of the Behavioral Health Administration of the Department of Health, which is located in the city of Kapolei, which is in the Ahupua'a of Honouliuli, in the Moku of Ewa, in the Mokupuni of Oahu, in the Pai'aina of Hawaii. We acknowledge Kanaka Maoli, Native Hawaiians whose land we gather on, who are adversely affected by health disparities that we as state health professionals are mandated to address across health programming by the Hawaii Revised Statute 226-20 or Act 155. As we get started, please go ahead and introduce yourself in the chat. And when you're where you're logging in from today throughout the presentation, please feel free to ask questions and we'll be monitoring your questions. Our topic today is substance abuse prevention services in a COVID-19 world. And we have 5 speakers joining us. First is Michael Walsh, who will present the results of a recent HPFS survey on technical assistance. Next, we will introduce our panelists, who will each present their approach to utilizing technology to provide substance misuse prevention services to youth at a distance during the pandemic. Following their presentations, I'll introduce 2 discussion questions. Then we'll open it up for questions and answers. As a reminder, if you're seeking continuing education units or CEUs for today's webinar, please be sure to fill out the survey that will be disseminated via email after the presentation. And with that, I will hand it over to Michael.
Fantastic, thank you so much. Anissa, if you can get the slides up there. So I'm here to present today on behalf of the Alcohol and Drug Abuse Division at the Hawaii State Department of Health. The presentation that I will be given will be a sort of brief overview of a survey that we recently conducted of the various recipients of funding under a program called the Hawaii Partnership for Success. This funding is provided by SAMHSA, and it's to support underage drinking prevention services across the state. We have a very broad group of subrecipients under this funding. They include the counties across the state, as well as our community coalitions and a number of evidence-based providers. We had a very strong rate of response across the entire population. And so I'm really happy to be able to present the survey results with you. Anissa, can you pull up the actual survey presentation, please? There we go. Next slide, please. So this is a brief overview of who participated in the survey. As you can see, we had about 82% coverage across all of our subrecipients, 100% across our counties. So each of the county representatives was included in this. Our expert work group, which is the State Epidemiologic Outcomes Work Group, was also included in this. Next. So one of the questions we ask looking forward is in the fiscal year that we're in right now, which started on the 31st of September, what technical assistance could be provided by the Alcohol and Drug Abuse Division that would be most useful for delivering the core components of substance abuse programming across the state? What we found was the list on the right. Next. So I wanted to point out a couple of things really quickly, and this is why we're having this webinar today. 3 things immediately stand out when we start talking about Web 2.0 services, or we start talking about digital communications. Social media, virtual training, and online platforms were named by many of the respondents in this survey. Next. Now, less obvious, but also related, are a number of other items that were pointed out as most useful. So logic models, this is the process by which we try to connect or think about how our strategies will achieve, how the outcomes from our strategies are connected to the resources, the inputs, the activities, and the outputs that we do in our programming. Many of those logic models had to change after COVID happened because many of the in-person services that were planned were no longer able to be implemented as originally planned. And so a lot of logic models had to change. data analysis also had to change. One of the reasons why data analysis had to change is because the remote delivery services that were being provided had different key performance indicators. So there's different data there. And so that was a huge challenge for many of the recipients of funding, for us and just across the state and across the country. It's a big change to go from in-person to remote delivery of services. Communications. So when we talk about communications, many times we think about traditional communications, media, but we also think about digital communications. So there's a strong overlap between what we're talking about with social media, what we're talking with online platforms and communications. Monthly meetings. As we know right now, we're doing a Zoom meeting. Last year, this might have happened as an in-person meeting. Many of the meetings that we had across this program were done in person until COVID happened. So there's been a huge shift to going online. Strategic planning is related to the logic models, but it's broader than the logic models. And I don't need to go into that too much, but you can imagine how moving to remote delivery services really, really impacts the strategic planning process. Policy development also changes. When we start talking about how do you develop policy, what are the processes at play, it gets back to the meetings, but it also goes much broader than the meetings. And the role that technology will play in developing policy is something that's still a challenge for many substance abuse providers across the country. And the last thing I want to point out here, and this is what's really interesting, the mention of ecological strategies. So what are we talking about with ecological strategies? What we're talking about is moving beyond the individual, the family, and the school. So we're looking beyond just that immediate institution and the immediate individual that's being served with prevention services, but looking at society writ large. And obviously, as we move into an online domain, that obviously broadens what the concept of society means in many contexts. Next. So one thing I wanted to point out here, contract requirements. Why does this come up, right? Well, I mean, one of the reasons it comes up is because when you enter into agreements and you're in funding arrangements as a service provider, many service providers are getting their funding from a health agency, whether it's at the federal level or the state level, or from a grant provider or someone else out there, and there's contracts in place. Well, obviously the contracts also have to be reviewed and changed as a result of this. And so there's modifications that have to be made. We often talk about things as midstream adjustments, or we talk about major contract changes. And so contract requirements is a huge area that many substance abuse providers want more technical assistance on. Next. Then we get into the rankings, right? So what we did is we provided the respondents with an opportunity to rank what type of technical assistance they wanted to receive in this current fiscal year. And what we found was number one was social media. That was by far the most important type of technical assistance that our subrecipients wanted to receive. After that, we have the communications, epidemiology, public affairs, strategy, and planning. And then third was technology and training. You can obviously see the connection between training and the others. Next. So I wanted to point out social media and technology. I mean, they immediately jump to the forefront. We talked about them previously in the last slide when it was listed, but you can see how important social media and technology are in terms of the rankings that the subrecipients made. Next. But again, it's broader than just social media and technology. I mean, this shift that we're making to remote delivery models is much broader than that, and it affects communications, planning, public affairs, strategy, training. Next. But it also impacts the type of expertise that you need to have. And I think this is one of the big challenges as we move into a remote world. There is a question of how do you do epidemiology around substance abuse when you don't have the opportunity to do the surveys in the schools? How do you look at big data? And how do you do that sort of work, right? So if you're a smaller subrecipient where you don't have those resources, but even if you're a large subrecipient, a university or a health agency or someone of that size, you have some new challenges around epidemiology as well. Next. So what was at the bottom? If we had done this last year, many of these things that were bottom ranked would probably have been top ranked. And that was one of the reasons I wanted to point this out in the survey. And moving forward, ADAD is going to start tracking these on an annual basis. And so that will help us provide some time series data to look at this over time. But this year, when we asked our subrecipients, what was at the bottom? So what is the least useful types of technical assistance that they could receive? You can see what popped up next. Now, when you look at bottom ranked, what's interesting is this move to remote impacts many of the things in this bottom rank category, right? So it affects the business model, certainly affects legal. And that's one of the things that's not obvious to many substance abuse providers. You know, when you move into providing prevention services, especially if you're providing apps, and Bear and Zach are going to talk about this later, right? You move into new legal domain, especially if you cross over into HIPAA data, right? Human resources, a huge shift, right? Now we have the opportunity in a place like Hawaii, where we have a big challenge in recruiting, certified prevention specialists and other people. You know, when you move into online domain, that changes everything. But then again, you also will be losing the cultural connection that you might need in order to be effective in your services by recruiting somebody from over in the mainland or overseas. And so that's going to be a big challenge moving forward. Operations. So when we talk about continuity of operations, right? When COVID happened, many organizations think of continuity of operations at the organizational level. They don't think about it at the program level. And that's obvious, right? That's something, when you think about how do you maintain your business, you think about how do you keep people going to work, right? But oftentimes the next adjustment that has to be made is how do you change your programs to be able to deliver the services, right? So it impacts there as well. Certainly impacts with marketing. You know, a lot of spend on posters, a lot of spend on traditional advertising for substance abuse programming has gone away. You know, everything is moved to a PNG or a JPEG file or something else that you put online, right? So that's a huge shift. And then I think the most important thing here, and I think this is something that shouldn't be bottom ranked, but I think it is because it's not obvious, is quality assurance. Because this becomes really, really difficult, especially when you have an intervening exogenous event like COVID, where you had this huge shift, right? Quality assurance becomes a big challenge at every level in delivering substance abuse services. Next. So one thing I wanted to point out here is telehealth is literally at the bottom, right? And so I wanted to go to the next slide really quickly to talk about why. So I think that the reason why telehealth is at the very bottom is because we think of telehealth as telemedicine, right? And we think of it as something that fits in the treatment domain, not in the prevention domain, right? So when we think about telemedicine, we have this definition from addictioncenter.com, and it's health information communicated over long distances between a patient and a treatment professional, right? But in other areas of public health, we see the word telehealth being used in a much broader context to carry over between treatment to prevention. And I think that shift will happen over time in prevention as well, but it hasn't happened yet. Next. So I wanted to leave you with one piece of qualitative feedback that we received from one of our subrecipients. And I think this is probably one of the things that resonated with me the most. And I think it hits it right on the head. So we asked the question, at this point in time, do you feel that you have sufficient training and resources to be able to effectively deliver the core components of your program? Why or why not? This is what we were told. No. With the changes due to COVID, capacity building must be approached from a different angle. We would benefit from more trainings that support having a fluent online presence and utilizing online platforms to their potential. Next. So what pops out to me here, right? So as someone who's coordinating the Strategic Prevention Framework Program for the state, where one of the huge components of that is capacity building, immediately capacity building pops out. And I see things like online presence and online platforms being connected to that concept of capacity building. This is in the context of the changes due to COVID. So what we're seeing here is, with this substance abuse provider specifically, is a recognition that COVID has shifted the prioritizations around capacity building towards the online domain. Next. So we're not going to have a discussion here about it right now, but I think it's a great segue into the panel that's about to follow. Thank you so much for your time. I'm really grateful.
Mahalo, Michael. Some really, really critical information presented right there that I hope we can circle back to in the Q&A. I wanted to introduce our panel speakers, and I think I'll introduce one by one. So we'll begin with Susan Frankel, and then I'll introduce the speakers as they present. So Susan Frankel has been serving as the Chief Executive Officer of the National Runaway Safeline, NRS, since 2018. Prior to joining NRS, she served as the Executive Director of the Chicago Foundation for Education, which provides support resources to teachers in the Chicago Public School District. Previously, she was President and CEO for Crayons to Computers, an organization dedicated to reducing childhood poverty in Greater Cincinnati by providing free school supplies and educational resources for teachers and low-income students. She has worked with many other child youth-focused organizations over the course of her career, including Prevent Child Abuse America, Voices for Illinois Children, the Illinois Department of Human Services, and the Annie Casey Foundation, and the Illinois Department of Children and Family Services. Frankel is not new to NRS, having served in the past as a volunteer in the Crisis Services Center, a member of NRS Board of Directors, and NRS Board Chair. She has also served on the boards of the Leadership Council for Nonprofits, the Lighthouse Youth Services Lighthouse Community School, and the Human Services Chamber of Hamilton County in Cincinnati, Ohio. Frankel holds a Bachelor of Arts from Washington University in St. Louis and a Master of Arts from the University of Chicago. Please welcome Susan Frankel. Thank you so much.
Thank you very much. I appreciate it. And I appreciate the opportunity to be with everyone this afternoon. So thank you. As I provide the information, which I believe, Anissa, are you putting up the slides eventually? Is that, so when we get the slides, that's okay. I just want to share, you'll see that the National Runaway Safeline, and I'll explain kind of more about who we are and what we do. While we're not specifically focused exclusively on substance abuse prevention, I just want to note that it is certainly a part of what we do, because I think as we all know, oftentimes substance abuse is linked with a variety of other circumstances, issues, and challenges that youth or families may be facing. So there's a number of ways that substance abuse prevention will intersect with what I'm talking about, but you will see that much of the information might be much more broadly addressing a range of topics and issues, but I will try to narrow it down and sort of emphasize that I believe that much of what we're doing can be applied in all different ways to a wide variety of topics, if you will. So if we just head on to the next slide, the National Runaway Safeline is an organization that we've been around for just about 50 years. We'll be celebrating our 50th birthday or anniversary in 2021. We're based in Chicago, but we do serve the entire US and US territories as well. Our mission is focused on helping to keep America's runaway, homeless, and at-risk youth safe and off the streets. We right now annually serve approximately 100,000 youth and families through our crisis services and connections. And we're currently in the process, we're really focused right now on doubling the number of young people and families we serve by the end of next year, recognizing that there is such an extensive need, and that given the type of organization we are and what we do, we certainly should be reaching a larger network or a larger group than we certainly are. What I also just want to sort of address is, as Michael was referencing, COVID-19 certainly changes and impacts how people think, how they look at your services. What maybe wasn't as important a year ago has risen to the top or changed significantly. In some ways, the National Runaway Safeline, because we provide 24-hour, 7 days a week, 365 days a year, crisis services via phone, chat, and online services, we were in somewhat of a we had somewhat of an advantage going into COVID because most of our services were already provided remotely, if you will, but it still has challenged us to think differently about how we provide those services and what we do with those services and how we work with other folks. So if we go on to the next slide, just to give you a sense of why we exist and what we do. This just gives you a little bit of statistics on homeless youth in this country, just that 1 in 30 youth aged 13 to 17 will endure some form of homelessness in a given year. And then 1 in 10 young adults ages 18 to 25 will experience homelessness in a given year. We know that this has certainly not changed over the course of this pandemic, if not potentially increased. So we're gonna flip on to the next slide. As I referenced just slightly, the National Runaway Safeline, the way that we provide our services is via a hotline, a live chat, which is essentially like an instant messaging service, email, an online forum, and then we have a range of prevention, outreach, and education services and resources. I know again in the earlier presentation, Michael referenced social media and the impact or the interest in how social media can potentially be applied to prevention services. We too are having very extensive conversations about this. We don't currently list that as a crisis services mechanism, but I do want to share we are looking at how we enhance and expand how we do use those functions. One of the challenges that I think would be consistent across the board with some of the other issues that are being addressed here is just how do we ensure confidentiality? How do we ensure safety and sort of protect any information that we might not want youth sharing, kind of out in the entire social media world, if you will. So just to give you a sense, I wanted to, if you go to the next slide, to just give you a little idea of what our reach would look like potentially in Hawaii. I know this is small and maybe a little bit hard to read, but I wanted to, we ran just some quick numbers just to get an overall sense of the number of young people who are reaching out to us. What I want to just state with these numbers, and this is by month, and we can certainly provide more detail, is while the numbers may themselves look fairly small, one of the things, this only counts young people who we have crisis logs for. It doesn't necessarily capture how many youth might be reaching out and going on to our forum, looking for information or resources, or using some of our things in the prevention realm, because we count those a little bit differently. But these are young people who have reached out to us specifically looking for crisis services and support from our hotline services. If we flip to the next one, just again, some Hawaii specific information, just to give you a sense of the top cities that were identified when we ran a quick data report, just to take a look at Hawaii. And then the demographics, some of which are pretty consistent with what we see across the country, which is females were nearly 3 times as likely to contact NRS versus males from the state. How young people reach out to us were evenly split between calls and chats. I will note this is something we're just getting ready to release a data report on our 2019 data. This was a fact that actually surprised us a little bit. We expected that disproportionately young people would be using chat or other online services far more than they are using our hotline or making phone calls. I do want to share, we are seeing still a pretty heavy use of our hotline and phone services. And then just a little bit of additional demographics on all of our data is collected as self-reporting. So a lot of times we don't always have all of the data for every young person who reaches out, but this was the self-identified information that we have. If you want to go on to the next slide. What we also do know, this is not for Hawaii specific, but overall, about 60% of the young people who reach out to the National Runaway Safeline have not left home or the living situation that they're in. This is just important because as we think about hotlines or other services like ours as sort of a means for providing prevention services or options for young people in terms of how they make their decision making, whether it's before they leave home or they make other potentially dangerous or other kinds of decisions. It's important to know how many young people might actually reach out for help before it gets to sort of a significant level of crisis. So as you look at this, this also then shows some of the things that we do through NRS to provide prevention services, or how we connect young people to community resources and support. So our goal is always, when a young person reaches out to us for help, is looking through a very significant, large national database that we have. Our goal is to always link young people and families back to local services and support. We do a lot of advocacy on behalf of young people and families, calling out, making sure those services available, making sure, particularly during COVID, that times haven't changed, or the services still exist, or there aren't other kinds of restrictions that they need to be aware of. We use our crisis intervention model to help young people walk through and make decisions about what feels right to them for making next steps and decisions about how to resolve whatever has prompted their reaching out to our services. We offer a conference call and mediation services. So if a young person is struggling with a family member or guardian or other living arrangement, we help to mediate a call that includes all of the members who are part of that, need to be part of that conversation. We also have our Home Free program, which serves as a family reunification, but also a transportation program that offers also transportation to an alternative living arrangement for young people. So again, while these things may not be seen necessarily as primary prevention, these are ways that we're able to work with all of you and with families and young people to offer sort of this range of services that can help provide solutions or options other than potentially living on the street, running away from home, or making other kinds of decisions. And then I'm going to just quickly walk through some of the other resources that we provide and programs that we have that I think will be more helpful as we look at how to provide prevention services via a remote setting. So sorry, I realize there's a lot to cover, so I just want to we'll jump through some of this. This is just to give an idea of the range of kinds of information and referral services that we offer, the kinds of questions that we often receive, and what young people and families are looking for when they reach out to us. So it shows you sort of the wide range of things that we offer and provide. And then if we jump to the next slide, I referenced our Home Free program, which is what this next slide is. Again, don't want to go into a lot of detail, but whenever I talk to a group, want to make sure that folks are aware of this. We do partner with Greyhound and provide free transportation across the country. I know that this becomes a little bit more challenging and difficult when we're talking about helping young people if they're returning home to Hawaii or have landed in Hawaii and are trying to go elsewhere. But this is one place where, particularly during COVID, we've been really creative and innovative in finding other options and working with other transportation partners, whether it's United Airlines, Uber, and some other kinds of options there. So let's move on to the next slide. So we do offer a free prevention curriculum. It is on our website, it's downloadable. There are actually 14 modules that make up this curriculum. Some of the focus is around making sure that we're helping to build life skills, education opportunities around a range of topics, and really making sure that we're offering young people, community groups, schools, after school programs, etc., access to this resource and something that should be easily applicable, whether it's in an in-person or a remote or online setting. If you want to go to the next slide. So this is just an example. These are the modules that make up and comprise the Let's Talk Prevention curriculum. So again, all of these can be downloaded separately, so they can be used in any order. And you can only use one of them if you would like, or you can use all of them. And if you scroll to the next slide, I just wanted to give a quick sense of what it might look like. This is just one module. So every module set up, so it gives you goals and all of the sort of outlines the module and the curriculum that's being covered. And then if you keep scrolling, it's going to walk you through. It provides pre and post testing activities to use and to apply, instructions on how to use this. different materials and things that you will need are all outlined within every module. And then if you keep going, there's one more, just again, to give you a sense of everything that's included. So every piece, and again, you just go to the 1-800-runaway.org and you're able to get this. And then we have staff who also provide technical assistance on how to use this curriculum and how to apply it. We did just recently offer a webinar on how to use this remotely and how to turn many of the activities and other things, how you can deliver them more virtually. So I am happy to share a link to that presentation as well, which will go into much more detail on how to apply this. So part of this is also just to say, outreach to us will always provide, you know, if folks reach out to us and are looking for certain things, we're willing to provide and are there to provide the technical assistance, the support, and other resources. So I just wanted to give you a taste of that. And then quickly, if we just want to keep going, just so you know about a few of the other things. One of the other things that we do offer that is actually covered in that curriculum as well is something that we call a kids call, which is something that we're able to help facilitate, where a member of the National Runaway Safeline staff will participate and work with someone from an agency or an organization. We'll do this virtually. It can be done via Zoom or via conference call or whatever setting that folks would like. And we actually walk through and provide, there's a video that goes along with this, along with a number of resources and other tips, but we literally walk through what it's like to reach out to a hotline or reach out for help. We do role playing and do a mock call. It provides an opportunity for young people to ask questions and to get comfortable with reaching out for help should they need it, and to actually practice before they might need it in the future. So again, something that we can arrange and are arranged individually with different organizations. And then we provide the technical assistance and support. So if we want to keep going, so we've just put together a few things again that sort of goes along that aligns with some of what we're doing on the prevention side and with some of our resources. So pulled this together. That certainly what we're finding, as I'm sure many of you all are, but we are turning much of our prevention work, many of our education resources and tools into online system, more usable, accessible, easy to use online systems, but we're really taking advantage of all of the different resources that are available in some of the online applications. But one of the things that I will encourage all of you is we have created a lot of this, so rather than you creating it yourselves, again, we're happy to offer all of this free of charge. And then I believe that there's one more that just addresses, I've provided some links and I'm happy to provide this presentation where we have some facilitator tips and some other resources if you want to go to the next slide. This is just some general facilitation tips for working and providing digital online services, as well as the additional cheat sheet that we just developed around remote learning. And then I think I only had 10 minutes, so I'm not sure if I've actually taken more time, but my contact information is there. I know we're going to have more discussion. There's so much to cover. The thing that I will emphasize is there are so many resources available on our website. And again, we focus on trying to make everything as free as possible, but I also just encourage you to take advantage of some of the things that we've developed, and we're happy if they're used in different ways. I always say beg, borrow, and steal is the best way to do it. That's what all of those things are there for, but also remembering that as the National Runaway Safeline, but particularly as a national hotline, from our experience during this pandemic and during COVID-19, hotlines are a great resource to really partner with and to take advantage of, because we are able to have our staff 24/7 And while we've had to deal with a lot of different things and change how we deliver our services and move our staff remotely, most folks who interact with us already, from everything that they know, we were remote anyway. And so I think that knowing that we're available, knowing that to refer young people to us in times where maybe you might not be available, keep in mind we're always going to be working with young people to be utilizing their local services. We're not there to supplant what all of you are doing. We're there to work with you and to be a partner and part of the continuum of service delivery that exists.
Thank you so much, Susan. And thank you for this wonderful option for our youth. We received a question in the chat during your presentation that I wanted to follow up with, but first, I wanted to say that all of the slides that you shared today, and thank you for generously sharing your curriculum so publicly, will be provided after the presentation. The question, I'll put it in the chat. It's how many states or even school districts have integrated prevention into their curriculum?
Is that a question? Is that a question for me?
Yes, that's a question for you.
I guess I'm not sure if I can entirely, to be honest, answer the question. I don't know if the question is how many states have integrated our prevention curriculum or just have integrated prevention into the school curriculum. So I think it would be helpful to know sort of what's being what they're looking for. One thing that I will say, when schools or after school programs or runaway and homeless youth programs or other programs are using our curriculum, what we find is they're typically, it's not necessarily that they're writing it into, okay, so how many states from our research? I have to, again, be honest, in the role that we play and in the work that we do, we're not necessarily working with every state entity and every school system to know what they've integrated into their particular curriculums. What we do is provide this curriculum and provide a resource, but it's being used by schools, after school programs, things like boys and girls clubs. It may be used by runaway and homeless youth programs or other providers. So it varies across the country in terms of how it's being used, where it's being used, and who's using it. I'm not sure that I can tell you that there's a state that's necessarily taken it and incorporated into sort of a specific statewide school curriculum or anything of that nature. I'm not sure entirely if I'm answering the question, but I'm trying here.
Oh, that's wonderful. I mean, thank you so much. I think it's getting a lot of our wheels spinning and a lot of food for thought there. So I would like to introduce our next speaker. Renee Wolff is a medical doctor affiliated with the Dartmouth Institute of the Giesel School of Medicine at Dartmouth College. We look forward to learning more about you, Renee, and your work through your presentation.
Thank you. And I wanted to thank Michael in particular who invited me. So I think I'm probably like the fish out of the water here. And I could go through all my credentials. I went to George Washington University for medical school. I did my surgical residency at Boston City Hospital, sort of in the Knife and Gun Club. I was in Boston as a surgeon for a while, and then I moved to Maine, where I was the director of their weight and wellness program. But other than what I've already gone through, rather than go through all my credentials, I think I'd rather start with an apology and a confession. I am Susan, and I really don't take care of or have much to do with substance abuse. So I'm not sure which is the confession and which is the apology. But I think that a project that I've been on may have a lot of overlap with a lot of the work that the people in this webinar are doing. I got interested in preventive medicine when I was the director of the weight and wellness program. I found that as we took in patients, we were giving them health messages and talking about weight and wellness, and these were mostly the parents of families, and the kids were getting the messages in another arena. And so I approached some people in the pediatric world, and there's a obesity prevention program called Let's Go, which is pretty popular nationally. And we thought it would be good to treat families instead of me treating the parents and them treating the kids, and try to sort of get some prevention messaging that would really hit people where they eat, live, work, and play. And that was kind of our motto, to get it out into the community. So that was the beginning of my prevention work. And then currently I'm just about to finish up my master's at TDI, which is the Dartmouth Institute, which is where Michael is as well. And as I was working with a group and completing some work for TDI, I really had the great honor of working with Maine Medical Center and an outreach initiative that they were piloting that involves the practical application of telehealth for public health. And so I think that I was asked to talk about that experience, about what we did using telehealth for public health messaging. And so that's what I'm going to talk about. And I got involved in this community outreach program that essentially uses Zoom as the format with the immigrant population of Portland, Maine. Next slide. So the immigrant community of Portland, Maine is like many immigrant communities and many other communities. The greater Portland area, Maine is a rural state. It's got, about 1.5 million people, and most of those people are concentrated into 2 cities. There's between 45 and 50,000 foreign-born people in the state of Maine, and in the greater Portland community, which has a population of about 500,000 people, there are between 10.5 and 11,000 immigrants and 4,000 refugees and asylum seekers. So this is the group of people this is the population that we were trying to reach. Many of these people are essential workers. They might work 1 or 2 jobs. They have difficulty getting to their doctor's appointments. There may be many people living in an apartment with 1 bathroom, and these may be many different family members who have a whole bunch of different medical issues. So I think we're fairly familiar, and my guess is there's overlap in this arena too, with some of the barriers that this disenfranchised and underserved population might have in terms of accessing healthcare, both preventive, chronic, or acute. They have the barriers of language. There are some cultural barriers. There's transportation barriers. And more recently, there have been some fairly intentional and significant barriers set up by the US government to dissuade immigrants from using healthcare. So not to digress too much, but there's something called the public charge rule, which has been in the US for over 100 years. But it says that if you are more of a drain than a contribution, if you receive benefits but don't have the ability to pay them back, or if you receive too many benefits, you can lose your green card and you can get deported. About a year ago, President Trump expanded what would be included in the definition of a public charge to include Medicare benefits, Medicare and Medicaid. And so as a result, there is something that's been referred to in the literature as the chilling effect. So even people beyond the scope of that legislation, which was just for green card holders, even people beyond that scope started to disenroll from Medicare and Medicaid programs. And there was a notable documented avoidance of healthcare. So this was kind of the background that prompted an interest in looking at some alternative ways to reach people. And then the pandemic hit. Next slide. So hospitals often have mandates to increase their outreach to communities. This is not news to anybody. And as part of the implementation plan for Maine Medical Center, which is a tertiary care center with a large catchment, including the majority of Maine, some of New Hampshire, and occasionally Vermont, the mandate was to increase their outreach to the community surrounding the hospital that they serve, and also to develop new platforms for emergency preparedness planning. And so the preventive medicine team at Maine Medical Center partnered with an agency housed in Portland, Maine called the Maine Access Immigrant Network. The Maine Access Immigrant Network connects immigrants, whether they are asylum seekers, whether they're documented or undocumented, or whether they're naturalized citizens, with services or milk or food or clothes or a car ride to a doctor's office, but they're really a link. And the linchpin for the Maine Access Immigrant Network is their community health workers. So a collaboration was forged between the hospital, this agency that provides access to resources, and with members of the immigrant community itself. Next slide. The goal was to address some of these gaps in access and information. The people who were involved from the hospital and from the community wanted to find a new paradigm to address the widening gaps that were being seen in terms of barriers to access and barriers to information. And the gaps were widening. I think you can look at any gap in the last 5 years and it's widened. Pick your topic, you know, in any arena, gaps are widening. There was also not only trouble in terms of access to healthcare, but there was also an issue with health literacy that needed to be addressed. And layered on top of that was this mounting fear and mistrust that was partly due to these rather aggressive legislative policies. And also, I think, a fear of the unknown and cultural fears that may come along with going to a new, living in a new country that has different ways of practicing medicine. You know, if you're talking about fear and mistrust, the Maine Access Immigrant Network had to get the ACLU to get the ICE truck out of their parking lot. So, I mean, it was real and palpable for a lot of people. So this project, which began before the pandemic, was intended to find a way to reach people that were disenfranchised and didn't really want to be engaged. And the point was to talk about certain chronic and preventive health issues that were identified as critical, whether it's diabetes, hypertension, substance abuse, mental health issues, or just making sure people cared for their hypertension and didn't get sicker. Emergency room care was not considered a benefit that would count against you. So there was a disincentive to getting preventive health and to managing chronic disease that was notably causing a problem in this disenfranchised community. So this project not only wanted to create an effective way to increase health literacy, but also to sort of bridge the gap, the widening gap, to combat the increasing fear and mistrust that was found in this community, and I imagine is present in others as well. And lastly, there was a strong desire to make sure that the participants were integral to the design, implementation, and adjustment of the program, following sort of a co-production model. And so, you know, we wanted to know from the community with the needs assessment, what were they looking for? How would that actually be delivered? And what were the best ways to include their information and sort of get that information back to the providers? What did they think was important? Next slide. Next slide, please. Thank you. Perfect. So one of the models that was considered early on was a model called Project ECHO. And I'm sure that there are some people in the audience who are familiar with Project ECHO, which stands for the Extension for Community Healthcare Outcomes. And Project ECHO has been around for several years and is a format for delivering healthcare information that's used across the US and is also used in dozens of countries across the globe. But mostly it's a teleconsultation model that's used between providers. So for example, if there is a physician who has a really complicated patient but lives hundreds of miles away, they can have a consultation with the the guru in the university setting who is the be all and end all for this subject, whether it's a mental health subject or liver cancer or whatever. The remote doctor can present that case to the expert, they can discuss it, and the patient does not have to travel. So all the information can be presented and the expert can give the expert opinion. So this is an important game changer because it's the knowledge that travels here instead of the people. And that was a key feature of how this collaborative group wanted to deliver their public health. They wanted to bring, instead of having the people come to the hospital or to the clinic or having them come to us, as it were, they really wanted to develop a way to bring us to them. And that, I think, was just a really important sort of breakthrough in how the people who were designing this program thought of it. Next slide, please. So we developed the Ask the Doc series. And the Ask the Doc series is basically a Zoom update and town hall meeting for health information. There's usually a doctor, it's me most of the time, one or two community health workers, and then a bunch of people from the community. The community health workers notify members of the community through sort of blast social media. They have identified, the community health workers are people that we call opinion keepers. They really know, they're embedded in the community, they're part of the community, they know all the people who are involved, they know who's got COVID, who needs milk, who's got what issues, who's dying, who's living, what their health problems are. So they really have their finger on the pulse of their respective communities. And so for us in this project, it was really critical that the community health workers were central to this effort. So it would usually be a doctor like me and one or two community health workers that would get the information out. Now, the time and the language for each Ask the Doc series would be posted on the Maine Med website. It would be posted on the agency's website, but really the notification by the community health workers is what brought people in. And they would send a blast social media post that would say, okay, remember you wanted this thing, it's happening in 5 minutes. And then the reminders, and that's how people come into it. The community health workers also act as translators and facilitators. So sometimes if particularly this was happening in the beginning, if there was a little hesitancy, they would get things going. They would know what questions someone might want to ask and they would throw it out there to try to heat the room up a little bit. So we do Ask the Doc Zoom meetings in 4 different languages for 4 different language groups. We do it in Lingala, which is a Bantu religion that's often spoken in the Congo. We do it in Somali, in Arabic, and in French. Next slide, please. So to date, we've done 20 sessions. Basically, the way these work is people sign in and people join the Zoom meeting either by phone, by video, or they listen in and text their questions in. So we were originally concerned, is Zoom too complicated? You know, who's got internet access? How does it work? Well, that did not seem to be a problem at all. People, I think because they know these community health workers and they're trusted members of the community, people will connect with them. So if they're not comfortable sharing where they are or who they are, they will, stop their video or blank out their phone number or just text a question. We have several houses where there's, 4 or 5 people around one phone or computer with sometimes a toddler crawling across. But people have found ways to connect to this meeting. And I think that's partly because the urgency of the pandemic has prompted greater interest in getting health information. And also because it's a very, very familiar group. And so we usually start by me doing sort of an update. What's going on with COVID? What are the numbers? What does it mean? Are we looking at outbreaks, community transmission? and also then a vaccine update. How does it work? What does it mean? We do a lot of myth busting, which I think has been particularly interesting, hearing what people's impressions are of the medical community and of vaccines and of disease transmission. And you realize that so much of it has to do with their personal story and where they come from, particularly people who've had experience with Ebola. And we usually try to slip in some kind of other public health message, like it's still really important to get your kids vaccinated. Here are some mental health resources. Maybe get a flu shot. There's a free clinic on Tuesday. So we're usually able to work in some other care messaging. The problem is, and I think Michael really alluded to this, the analytics are really tough, especially for quantitative data. So we're in the process of gathering qualitative data, and we've got it, a bunch of anecdotal data sort of indicating that this is a great success. But some of the things that have risen to the top as we look at the transcripts, or as we get testimonials, or as we survey the community health workers, are that this has really been an important means of building trust. And since public health requires partnerships, the relationship building has been very important. We're starting to understand how it may have affected health behaviors. And again, it's on an anecdotal level, finding out whether people are getting vaccinated or for the flu vaccine, whether they're wearing masks more. We have a lot of interest in how to get adolescents to follow protective behaviors. And recently, in the last 2 to 4 weeks, there's been a lot of vaccine hesitancy information that we're getting. It's very difficult to administer a poll or give a survey with this group because of the language barrier. But what we do is we usually get 2 questions in at the end, and we just survey the participants how many people would get a vaccine if the vaccine was available today. And then we do it again another time with another group. And so you can sometimes get a little bit of the, test the temperature of the water, but it is very difficult to get any objective data. So that's sort of what our efforts are focusing now, is how to get that objective data and what are the ways that we can do that. Next slide, please. So for us, this has been a really effective way. We're reaching between 15 and 20 people now with every session, and we're starting to see that 75% of them are people that were not there the last time, but then we sometimes get people back. So it seems like it's sort of got a wider appeal. It's inexpensive. You need a Zoom account, and you need to be able to pay your community health workers. We're funded through a grant because community outreach was part of an HRSA grant that the Department of Preventive Medicine received. That's funded for 2 years, but this is really pretty cheap, mostly because I'm volunteering. But even so, in terms of other ways of getting to people, it's been fairly inexpensive. The technology is familiar. By this time in the pandemic, there really isn't anyone who hasn't been on Zoom or isn't familiar with it. And that is true of these impoverished, disenfranchised members of our population as well. And we know that the safe environment has been something else that we're starting to really appreciate. There was, they have developed a relationship with the doctor involved that they don't want to let go. And I think that's a particularly interesting part of this is, and I think that it's as if I'm being invited to their house for dinner. I'm the guest. And so in the beginning, it was a little bit awkward. They didn't know me. And now, it's like we can banter back and forth. And I can tell the tenor of the questions. This is another thing that we're sort of looking at is are things getting bolder? And it does seem to be that way. People are willing to challenge me more, particularly on certain, social determinants of health and being white. And, so I feel like that is a really good indication that the relationship is strong. But they all know each other. And the community health workers are trusted. And that's been a really key feature of this, is that I'm the guest and they're the ones running it. And so that has created an environment that I think has allowed for a much more rich and robust conversation. For us in this pilot study, with having done 20 sessions, it seems to be a pretty effective platform for public health messaging. It will likely be expanded to include the emergency preparedness component. It certainly would not be difficult now that the community knows that when these community health workers send out a message about something and that one of us will be there, that they can connect. And so I think that the fact that it's tried and true increases the effectiveness of that as a platform for public health messaging. And I also think it has wide application potential. Maine Med is now looking at starting this in the substance abuse and in the alcohol abuse prevention world. So the success that we've had has certainly gained some ground in other arenas. And I think that they're talking about launching that program in the next 3 to 4 months. And I would just sort of reinforce that the facilitator is key. Having a trusted member of the group that can be there to hold their hand, they enter into what can be a new and perhaps frightening situation, has been a big plus. And it also provides, I mean, like, you know, Zoom is remote, but it's still face-to-face contact, which has sort of the underpinnings of this building of a relationship to provide effective public health messaging. Other things that we're thinking of doing, I know that the Maine Access Immigration Network is going to start having a virtual office hour. So they're going to have a few of their community health workers available by Zoom from 2 to 3 o'clock on a certain day for anybody who's a newcomer. Anyone who has a question about how to be a newcomer and what to do can just show up at that Zoom. So I think that's been also a byproduct of this program, is the idea that there may be some virtual office hours that are being developed in the community. Next slide. This is the team that I just wanted to thank that really has made this outreach program possible. And that's it.
Thank you so much, Renee. So many great things happening in Maine that I think connect with the things that we're doing here in Hawaii. And we did have a question about accessibility. So we have 25 minutes left in our session. We may lose some time for Q&A, but for Bear and Zach, if we could, if it does come to mind that internet access has been an issue for us here in Hawaii, that would be wonderful. And so I wanted to introduce our next speaker, Zach, and hopefully you can help us to learn how to pronounce your last name, is the Executive Director of 18%. Go ahead.
No, go for it.
Okay. Is Executive Director of 18%.org. His passion for mental health support began after he lost a close family friend by the name of Lewis, who had bipolar and schizoaffective disorder. He went on to raise $40,000 through crowdfunding for the National Alliance on Mental Illness, NAMI. The proceeds were used to support teens who have mental health challenges. Aside from 18%, he is a mental health diplomat at Johnson & Johnson and a TEDx speaker. His passions lie in technology, community, and nutrition. When he's not working, Zach loves to travel the world, listen to podcasts, and work out. Welcome, Zach.
Great, thank you. So can I share my screen so I can present the deck? Great, that's okay. And just, I wanted to let everyone know, I do have COVID, so I may sound a little off, but I thought this discussion was really, really important. And thank you, Michael, again for inviting me. So yeah, so my last name is Schleien, Executive Director of 18%. And it really started at a close family friend by the name of Lewis, who had bipolar and schizoaffective disorder. And one day he went for a walk and didn't come home. and his remains were found near a river. And in his honor, I ended up raising money over the course of 2 campaigns. This was the second one. This second one, raising over $30,000 to support over 600 family members with loved ones with mental illness. I donated the $40,000 to NAMI, National Alliance on Mental Illness, and I decided I wanted to do something more and start this organization, 18%, which is a peer-to-peer support online community. So again, it is peer-to-peer support. We're not out to diagnose or treat any sort of mental health condition, but things such as addiction are areas where 18% covers. So again, you could be anonymous, so you could use as little information or as much as you would like in the community. Again, peer-to-peer support, and there's no cost to participate. It's also global. About 90% of the community is US based, and it's hosted on a platform called Slack. You could think of Slack as an online chat service. And the beauty of Slack is that it works on your web mobile device or even a tablet device. So you could use it really wherever you go, or even at work, given Slack is often used at businesses as well. So versus being in, let's say, a Facebook community where your boss may question why you're on Facebook, Slack, they don't really, they wouldn't look, they would look the other way, given Slack is synonymous with business. So this is an example in the community. As you can see, it's very, very supportive. It's a peer-to-peer support community, as I mentioned. And in the community, there will be people who will ask questions, and there'll be other people who will provide support. So it's really a supportive community, and you go to different, in the Slack community itself, there's different channels. So you'll see addiction, but also COVID, bipolar, depression, and so on and so forth. So you join as few or as many channels as you'd like. And then if you do express something like suicide, we do have technology set up that is automatically triggered, giving you the crisis text line number, the suicide hotline number, as well as international line numbers, as well as other resources as well. So we try to do everything in our power to bring you to professional resources if this community isn't providing you what you may need as if you're in crisis. But one thing that does allow members to stay safe, and I think one thing that has been very important for our success is the role of moderators. So we have many moderators on the platform. These moderators are also from suicide hotlines or crisis text lines. Again, they're not medical professionals. Their goal is to ensure that people follow the code of conduct. If people have questions, they can answer them. But if a member is under the age of 16, we actually reroute them to other platforms, given that Slack is a 16 plus platform to use. So we follow Slack's terms and services. But again, the role of the moderator is to keep people safe. They could also delete messages and just keep the community safe overall. So it's a very engaged community. We have over 15,000 members. We have close to 3 million messages sent. And it does skew younger. So 40% are between the ages of 16 to 24. Most of our members are now coming through all the suicide hotlines around the country, including the crisis text line. So how it works is if someone calls one of these hotlines, or text one of these hotlines and they're looking for support, we are a trusted referral where they can get that support. And I think what it comes down to is actually have that feeling of community. And the reasons for using 18%, the number one reason is for that emotional support and to feel less alone. And when you have community and when you're going through something such as addiction and there's other people who are going through it, or perhaps they've already, they're on their road to recovery, it's a really incredible supplement to therapy as well. And 35% of members discussed 18% with a family or healthcare professional. So it's something that people discuss with their family and has acted as a stage gate to getting in-person therapy as well, which I'll talk about in a second. Endorsements, we've been endorsed by Vicki Harrison, who's from the Stanford Department of Psychiatry, been endorsed by members at Johnson & Johnson. We've been endorsed by Robin Williams' son, Zach Williams, and the list goes on and on. And I'll read you this one quote from a member of 18%. I love how 18% is moderated by peers. I feel that people connect better that way. It's also helpful to share our experiences of psychosis so we don't feel so alone and shameful about them. There's value in what we've been through, and it comes out in these discussions. So again, I think the true value of 18% is community. Whether you're facing addiction or have any sort of mental health challenge. And as I mentioned, many of the hotlines will refer out, such as NEDA, which is the largest national eating disorder association, as well as the crisis text line. And just recently, I'm very proud to say, we were published in the Mental Health Review Journal, establishing efficacy in our community around how online mental health community, like 18%, leads to increased self-efficacy, and where it has allowed for people to actually get in-person or online therapy, as well as supplementing with online therapy, online peer to support using a platform like 18%. Aside from the community itself, we also have a monthly newsletter, which gives resources and other tools to our members. So it gets delivered into their inbox. So when you're in the community, you may miss something, given it is all real time. So having a newsletter, it allows us to provide additional resources that you can read whenever is convenient for you. Aside from the newsletter, we also offer a peer-to-peer mental health support course, which is a paid course, and you can get certified in 4 hours, and you'll receive a badge when you receive your certification. So as you could see, 18% the community, again, totally free, is this hub, and then we have different resources such as the newsletter and the course itself. And we've been covered in publications such as the Washington Post and now this. Okay, thank you.
Thank you. And just very inspiring, everything that you put forward. We certainly use Slack in our business, and just amazing all the possibilities that are there. Thank you for sharing, and we wish you all the best in your healing journey from COVID-19. I'd like to introduce Bear Matthews as our next speaker. He's the head of relations of Astra Labs, an international nonprofit that develops technology for communities in need. Personally recognized for having negotiated and signed dozens of public-private strategic partnerships in the past year alone, Astra Labs is valued internationally for their proven capacity to facilitate collaboration between big tech and healthcare. With Bear being just 20 years old and with Astra, a youth-run NGO, Their work has received significant praise from CNN, Mashable, Swiss Digital Days, TechCrunch, Basel Innovation, and more. Welcome.
Thank you very much. First of all, thank you to Michael for inviting me, and to all the speakers previously. This is a great panel on an even more important topic. So I'm happy to see so many participants and all of us here. With that in mind, I guess I'll start. Well, first of all, there's no deck. I feel like panel discussions are better face to face. So it's just you and me on this. Who is Astra Labs? As previously noted, we are an international nonprofit that operates in technological development for communities in need. So what does that mean? In short, on a quarterly basis, we rely on our advisory board and open submissions to identify communities in need around the world that could benefit from the support of technological development in the issue at hand. And so before going into the products that we've developed and published for these quote-unquote communities in need, I'll begin briefly by touching on how we develop them. So I think this is one of the most important topics in healthcare technological development. It's the how and the why. First of all, we're extremely hands-on. We work hand in hand with the communities for which we develop in. We have a three-part ethos to this. Part one is to ignite dialogue. Part two is engage a narrative, and part three is create community. Once we have been on the ground talking with community members, frontline workers, healthcare staff, and those for which we are developing for, we go into a research phase, which we allocate as the identification of need. Why is Astra Labs here? How can we help? What is our purpose on the ground? This is usually executed over a 3 to 4 week period, where I and my relations team will travel, or in this time, Zoom call, with these communities in need and go through a diverse and extremely valuable reflection on, well, first of all, why they need help, why Astra Labs is the person to help them in this situation, and what technologies can be applied to their position of need. After this month-long period, we go into a what we call a patient partnership design phase, wherein we want our products to be designed hand in hand with the patient or community in need. This is essential on a back-end sequence loop for us, because it turns out to be extremely efficient that if you design a product hand in hand with the patient, that they are A, extremely more likely to actually use the product once it's publicly launched, and B, extremely more receptive to providing user feedback and suggestions for further improvement. This is essential when developing technology for healthcare. Moving beyond the design phase, we take all our research, we take all our first-hand accounts and experiences, and we go into an advisory and internal research phase. And this is where the Astra Labs team relies heavily on our advisory committee, which is made up of roughly 4.5 institutional medical advisors throughout the United States and several abroad, but it's mostly, I think, 3.25 dozen of them are within the United States. And then the private side to that advisory committee comes through our partnerships. Most of our applications are developed within the area of mental health. And so our partnerships include Crisis Text Line, I liked that, Schleien Text, BetterHelp, and then some smaller ones like Grief Coach, Breathe App, if you guys know that, 10% Happier, and several others, depending on the field for which we're developing in. We'll go through this iteration phase for roughly an additional 2 weeks, really allocating what technological resources and development techniques can be identified and targeted towards the problem at hand. And then we go into development. As a technological nonprofit, development is essential for us. It has to be quick, efficient, but most importantly, it has to be secure. I mean, we're in an age of digital privacy, and well, with digital privacy, I won't go into digital privacy too much because this is a rabbit hole that all of us can get lost in. But the foundation of digital privacy at Astra Labs is our ethical development framework. Number one, no data will ever be harvested or sold through our applications. Number two, all of our applications and products will be provided for free forever. Next, we will never allocate any space for advertisements within the applications. And number four, we will never develop an application without hands-on, on-the-ground research. That's the baseline. There's a list of about a dozen of them, but that's the gist. Our development phase for applications for communities in need usually lasts around 2 months. And this is really cool. This is one of the special features of Astra Labs, because development iteration cycles for iOS and Android applications is usually, whether it be in the public or private sector, in the realm of 8 to 12 months for a beta 1 product, and then an additional, call it 4 or 5 months for review and then public launch. We do all this in 2 to 3 months. And how? Well, the how begins with the research that we do on the ground with the patient and the designing phase upfront. By doing research and development and design upfront, hand in hand with the patient, with the community in need, you throw out roughly, we publish research on this, for which my email is barrett@astra.org if you want to email me. Our website is also withastra.org. But basically, by doing this research and design hand in hand up front, you cut out roughly 6.5 months of back-end cyclical development. It's simple. So we go through a development privacy phase, and then we do launch and review. Launch and review, there's obviously roughly a week-long period. We'll do some PR, set it all up, but mainly we will be talking with the communities in need that we've designed and developed products for, and making sure this, whatever the product is, addresses the problem at hand. So that's sort of the design, ethics, ethos, and iteration phases that we go through. Now, the products. As I said previously, Astra Labs focuses primarily on mental health, mental illnesses, and minority security. On the first topic of mental health, we have published and launched 3 products in this space. The first is a product named Etheria. It is an application available on iOS and Android. It is a full-service CBT, DBT, mental illness support tool that services roughly 250,000 users across the United States, again, with a margin of that being abroad. Etheria was recently redesigned and relaunched 2 months ago with the vision of tripling our user impact. The second product in this space was our response to the COVID-19 pandemic, and it's a website called isolatednotalone.com. What came with this was actually a user input from the relations team at Astra, wherein one of our team members had been talking with frontline workers for several months on end, and he had a close relationship with frontline workers in New York, and a feedback that he'd been getting was many of the institutions of care for which our doctors and institutional professionals would usually seek, that is on the mental health side of things, have been shut down because they were not essential. I forget the wording for it, but they were not essential provisions of care for the frontline workers themselves. So the frontline workers that were taking care of our COVID-19 patients no longer had space to vent, relax, and talk to somebody about the experiences that were being witnessed on the front lines. And so what we did was we built Isolated Not Alone and partnered with roughly 24 US-based institutions to provide free mental health counseling to what turned out to be 100,000 US-based frontline workers. This was a fascinating research study for us, both in product and theory form, because the site was conceptualized, designed, executed, and launched in under 4.5 days with the partnership of, as I said, 24 mental health resource partners across the United States. And by the end of its first month, it had garnered 45,000 signups from frontline workers. And these are verified signups because we had an iteration sequence wherein, obviously, if you publish a site that's offering free mental health counseling to frontline workers specifically, that you have to have some sort of sequence wherein you verify that these are frontline workers. And so we had a sequence where they had to take a snapshot of their identification badge and their badge number. And for those of you who work in the healthcare industry, there's a badge ID number for which you can reference and verify online. So within the first month, we garnered 45,000 frontline workers seeking mental health counseling online through our partners. Great. The development of Isolated Not Alone and the feedback from that development transitioned into our tertiary development this year. And that was something called wobble rooms. And so the concept of wobble rooms plays off 2 factors. First is, as doctors and medical professionals exit the ICUs or places of trauma, in traditional non-COVID experiences, there would be counselors and or spaces for which those same doctors can talk to each other about the experiences that they've just endured. This research, which is actually fascinating if you're interested, goes back to an old British Army research study on preventing PTSD from soldiers returning home. And what it analyzed was...
So sorry, Bear, I think we might get logged out of the session in like 30 seconds, but we are very interested. So sorry for this rapid wrap up.
No.
But we had a question about your project, and we will share your contact information so everyone can follow up. Please be sure to fill out the survey after this presentation and include any questions that were not addressed. We will absolutely follow up with answers to your questions. And thank you to all of our generous panelists today. Wishing you all of the best and safety in all ways. And please tune in for the next webinar, which will be on Wednesday, I believe, at 3 p.m. Hawaii time. So take care. And with that, we'll say goodbye.